Good morning, everyone. Welcome to this week's Department of Medicine Grand Rounds. Before we get started, just a few quick housekeeping points. Please make sure your mics are muted during the presentation. Also, we ask that you hold your questions and comments until the end, at which time you may unmute yourself or put your questions in the chat box. And lastly, the CME credit on the screen will be displayed at the beginning and end of the presentation. Today's speaker is Dr. Jeffrey Laurence. Dr. Laurence is a professor of medicine in the Division of Hematology and Medical Oncology at Weill Cornell Medical College, attending physician at New York Presbyterian Hospital, and director of the Laboratory for AIDS Virus Research at those institutions. He is the senior science programs at AMFAR, the Foundation for AIDS Research. He is also editor-in-chief of two medical journals, AIDS Patient Care and STDs, and Translational Research, formerly the Journal of Laboratory and Clinical Medicine. His current research focuses on thrombotic microangiopathies associated with complement activation and microvascular cell injury in HIV and other disorders, including most recently COVID-19. Please join us in welcoming Dr. Laurence for his talk on thrombotic microangiopathy.
Thank you. Glad to be here. First of all, financial disclosures. I've received research grants and speaker fees from AstraZeneca, Omeros, and Sanofi that make drugs that are used to treat TTP and atypical HUS. First of all, how do we identify a thrombotic microangiopathy? Well, the major issue is the four major TMAs: TTP, thrombotic thrombocytopenic purpura, atypical hemolytic uremic syndrome, Shiga-toxin hemolytic uremic syndrome, and DIC overlap significantly. They can all cause thrombocytopenia. They can cause microangiopathic hemolysis, as evidenced here on peripheral blood by those fragmented red cells, low-grade fevers, renal disease, and CNS disease. Just a couple of general clinical highlights, however. About half of all atypical HUS cases have prominent CNS findings, and 20% of cases of HUS present with normal serum creatinines, even though they have the word uremic in their title. If you bother looking at the sediment, if you bother measuring new proteinuria, new hematuria, or new changes in blood pressure, you may find them, but 1 out of 5 times, if you're just looking for change in creatinine, you may not see it. And then a clinical pearl: the lung is frequently involved in atypical HUS, typically with bilateral pulmonary infiltrates that are confused with pneumonia or pleural effusions. They basically do not occur in TTP. And this is true through multiple autopsy studies before we had adequate therapies for TTP, biopsies, etc. The lung frequently involved in HUS, the lung never involved in TTP, and we don't really know why. And finally, the major point is both thrombotic microangiopathies, if you read a textbook, were considered to be ultra-rare disorders, about 2 cases per million of the general population. But good news for companies that have drugs to treat atypical HUS, this is not really true, at least not for HUS. There's increasing recognition of so-called secondary complement-driven thrombotic microangiopathies linked to infections, to allo stem cell transplants, renal transplants, autoimmune disorders, particularly lupus, that raises the issue much more. In fact, in our hospital, I would say we probably see about 4 or 5 TTP cases a year, probably 8 to 10 classic atypical HUS cases, probably even more. This basically just says what I've said before. There are 4 major types of TMAs. I just want to emphasize that the major points in terms of diagnosis: DIC, you'll have an elevated INR and PTT. I don't know how to discriminate between TTP and HUS in the setting of active DIC. It's basically treat the DIC and call me in the morning. TTP, as I'll show you in a pathophysiologic slide, the sine qua non is a low ADAMTS13 activity. 95% of the time, patients with TTP are immune-mediated with an autoantibody against this enzyme. About 5% of cases are congenital, where the ADAMTS13 level is 0 and it's due to mutation. Atypical hemolytic uremic syndrome, you should have a normal ADAMTS13. In about 70% of these cases, you can document congenital mutations in the complement system. In the other 30% of cases, even though they respond to anti-complement therapy, you may not be able to identify mutation. We'll talk about that later. And then finally, there's Shiga-toxin producing atypical HUS. You diagnose this obviously by doing a culture or smear in the stool and PCR. and both should be performed because there are some types that we do not pick up by PCR alone if you're just looking for the standard type. And then one thing we fail to consider, and I've actually seen 3 cases now at New York Hospital in adults, is cobalamin C deficiency, vitamin B12 deficiency. In the literature, this is called pseudo-TTP. That's a misnomer because the ADAMTS13 is normal. It should really be called pseudo-HUS. It's about responsible for upwards of 10% of cases of TMAs in children and neonates, rarely in adults, but again, in my checkered career, I've had 3 cases. You rule it out by measuring levels of plasma homocysteine and MMA. And when should you rule it out? Well, just about any time you're considering atypical HUS, you've ruled out Shiga-toxin HUS, you've ruled out TTP, and it's particularly pertinent if you have a case of a rip-roaring thrombotic microangiopathy, LDH in the thousands, haptoglobin of 0, and you've got a low reticulocyte count. One of the things you should consider is, could this be a cobalamin C deficiency? Okay, so how do we make a diagnosis in TMA? And this is an algorithm that I published about 7 years ago that's reproduced widely. First of all, you need thrombocytopenia, but you need to understand what thrombocytopenia means. TTP is a platelet consumptive disorder. The median platelet count in TTP is 20,000 or less. If you biopsy anything vascular in a patient with TTP, you're going to find a clot. It's predominantly going to be a white platelet-rich clot, absorbing a lot of platelets. Atypical HUS is not a platelet consumptive disorder. That's why the median platelet count in atypical HUS is 30,000 or greater. It's why this algorithm approved by the NIH, by the FDA, says your platelet count in HUS should be less than 150 or a 25% decrease from baseline. Because I've seen multiple cases of severe atypical HUS in our hospital, and this is certainly in the literature, with platelet counts in the 200,000 range. And my personal best was a consult that I got from our sister medical school in Doha in Qatar. Some of you may know that Cornell was offered $500 million to build a medical school in Doha, so we built a medical school in Doha. They're graduating now, they're, I think, 5th medical class. And I get a phone call from a pediatric hematologist saying, we have a difficult case. And I disagree with the nephrologist who wants to do a biopsy in this 2-year-old because the LDH is 2,000 and the creatinine is 10 and the haptoglobin is 0. And there's schistocytes, fragmented red cells all over the peripheral blood. They insist on doing a renal biopsy to make certain this is a true thrombotic microangiopathy. And I said, why? You've diagnosed a hemolytic anemia. You've got a 0 haptoglobin and a high LDH. You've diagnosed an organ system dysfunction. You've got a creatinine of 10, and you've ruled out TTP with that ADAMTS13 that's normal. What more do you want from my life? And she said the platelet count's 1 million. And I said, I don't care. Maybe the person's real platelet count is 1.5 million, and that 1 million is a 25% decrease from baseline. They did the biopsy anyway. It had a TMA. The very next day, the platelet count went from 1 million to 750. It just showed, and the patient was successfully treated with anticomplement therapy. So don't be fooled by thrombocytopenia. Microangiopathic hemolytic anemia. You want to see schistocytes on the peripheral blood smear, but you need to look at that peripheral blood smear all the time, every day. I've been involved in 3 lawsuits now, failure to diagnose TTP or HUS, where because these are lawsuits, they send me the slides. And I agree with the hematologist, no schistocytes on day 1 or day 2 or day 3. I'll find them on day 4 or 5, but who bothers at looking at the smear every day? Tell your fellows to look at that smear every day. Because what's a schistocyte? It's a fragmented red cell. What happens to fragmented red cells? They get sucked up by the spleen or extravasate into tissues. Elevated LDH, decreased haptoglobin, decreased hemoglobin is in any hemolytic anemia. Then you want organ system dysfunction. Any organ can be involved in any TMA with the one clinical pearl. The lung is frequently involved in HUS. The lung is never involved in TTP. There's something called a plasmic score. Some people would rather use the French score. Plasmic score has 7 components to it. The French score is 3. But there's basically only 2 things you need to pay attention to here. And that is you have a patient that has a unexplained acute kidney injury, has a change in platelet count, has a hemolytic anemia. You're concerned, could this be TTP versus HUS because you've ruled out the IC. Consider what the absolute platelet count is and what the absolute serum creatinine is. If your absolute platelet count is less than 30,000 with a relative risk of 22 in the presence of a TMA, that's TTP. What's your serum creatinine? If your serum creatinine is less than 2.3 in the presence of other evidence of a TMA, that's TTP, not HUS. And the plasma score you may mention in here also includes look at the MCV. It's kind of a poor man's test for whether you have a dysfunction in vitamin B12, but it's in there. Okay, so if you understand this slide, you'll understand most of everything else I'm going to say. TTP, you injure a microvascular endothelial cell. Injured endothelial cells pour out von Willebrand's factor, which bind together to form ultra-large von Willebrand's factor complexes, which tether platelets. Those large aggregates of von Willebrand's factor with platelets plug up the injury in the endothelium. Once that injury is taken care of, you want to stop that process from happening. And what stops that process from happening is an enzyme known as von Willebrand's factor cleaving protease activity, otherwise known as ADAMCS13. ADAMCS13 working, no clotting problem, no TTP. But what if you had an autoantibody against ADAMCS13 or in 5% of instances, congenital deficiency? Then that process continues unimpeded and you get the clotting disease we call TTP. What about HUS? TTP in the vast majority of instances is an acquired autoantibody disease. In atypical HUS, in the vast majority of cases, it's a congenital susceptibility to be unable to control the complement pathway. Okay, so you punch a hole in an endothelial cell in someone with the inability to control complement. Usually the stuff that's injuring that endothelium, like an infection, like autoantibodies in lupus, like one of our most potent stimuli, anti-HLA antibodies, explaining its association with allotransplants and renal transplants, you activate complement. And also you've injured endothelium, you're activating thrombin, and thrombin is a pretty good C5 convertase. And all of this is breaking down complement factor C5 into C5a, also known as anaphylatoxin, and C5b, which promptly joins to 6, 7, 8, 9 in the blood and on tissues to form a complex known as C5 beta 9, also known as MAC, or membrane attack complex. And membrane attack complex does exactly what it sounds like. It punches holes in endothelial cells, it punches holes in red cells. C5a activates platelets. So you've got an inflammatory component, you've got a thrombotic component. And if you can't shut that process off because you either have a loss of function in some complement regulatory proteins, or in adults, in rare instances, an autoantibody against one of them, or in very rare instances, gain of function in C3 itself, or complement factor B, you get the clotting disease we call HUS. So how do we treat these things? Well, in TTP, you've got an antibody against ADAMCS13, or you're congenitally absent, so you want to replace the ADAMCS13. So you do plasma exchange. You do plasma exchange basically because fresh frozen plasma has a fair amount of ADAMCS13, and you're creating space to get more fresh frozen in. And the least important component of this is to remove the autoantibody inhibitor. I say it's the least important because these are all IgGs. As you all know, we're real good at getting rid of IgMs, not so good at getting rid of IgGs with plasma exchange. And I'll talk about the newer therapies that we need, like immune suppression and immediate blockade of von Willebrand's factor binding to platelets in a moment. What about atypical HUS? Well, in typical HUS, you need to inhibit that ongoing complement activation. So while you're working on whatever the inciting episode was, treating the HIV, treating the COVID, treating the lupus, etc., you want to stop that process from happening, and there are only 2 FDA-approved drugs to do that. Both of them are monoclonal antibodies against C5. One of them is known as eculizumab, Solaris. The other, a longer-acting form of eculizumab, ravulizumab, also known as Ultomiris. Okay. Now, that's just plasma. We've probably known for about a decade that plasma exchange alone is a poor way to treat TTP, because the real pathophysiologic injury the stuff that's driving all this is the autoantibodies against ADAM-CS13. So you need to shut those off. And the vast majority of individuals and hematologists that treat TTP would simultaneously start with their plasma exchange, steroids and rituximab. And this is just showing, this is from a paper in Blood about 5 years ago, showing the difference in relapse survival, which is quite striking in individuals who are only given plasma and steroids versus individuals giving plasma, steroids, and rituximab. But there's something even more important than that and there's increasing, there were about 6 or 7 abstracts about this at ASH last December, a couple of papers in Blood recently, saying that if you follow patients that look to be like in complete remission from TTP, that is, they have normal platelet counts and normal creatinines, normal LDHs, there's still some problems that are ongoing. Neurocognitive impairment are found in at least 25% of these long-term survivors. Recently published in Blood, subclinical, i.e. MRI detected cerebral infarctions, although in the discussion, the author said, forget this word subclinical, these people have cerebral infarcts. Risks for hypertension and stroke. Very recently, a paper published on subclinical myocardial injury and persistent chronic kidney disease. So the hypothesis here is if you really shut off the process of binding of von Willebrand's factor to platelets very early on, if you just didn't wait for plasma to get enough fresh frozen in, if you didn't wait months, sometimes many months, for Rituxan and steroids to work, you could block some of these long-term sequelae. And that's why in 2019, a new drug was FDA approved known as Cablivy or caplacizumab, which binds to the A1 domain of von Willebrand's factor. That's the domain by which von Willebrand's factor interacts with platelets to immediately block it. And so the new thinking about how we treat immune TTP, it should be a triplex of therapies. Once you've made a diagnosis of TTP, you've got low ADAM-CS13, fine, start plasma exchange. Fresh frozen contains a lot of ADAM-CS13. You've recognized as an autoantibody, fine, get rid of those autoantibodies with whatever you want. That's typically steroids and rituximab. But while you're waiting for all that to work, you want to immediately stop this process from happening, and that is introducing caplacizumab, which is given as an intravenous infusion right after plasma exchange, followed by a subcutaneous infusion and subcutaneous infusions for the next 28 days, as long as the ADAM-CS13 is still less than at least 20%. And this is just a schematic of that showing that ADAM-CS13, which is green, autoantibodies are inhibiting it, and caplacizumab blocks that process. Randomized clinical trials, 2 of them were published in the New England Journal. The most recent one published was the Hercules trial. The most significant parts of all this was there's a 74% decrease in the main endpoint, that is major thrombotic event, TTP recurrence or death, which was highly statistically significant in individuals that were either given just plasma exchange, rituximab, and steroids versus that group of drugs plus caplacizumab. And perhaps most striking and most interesting to hospitals, because these are expensive drugs. A dose of Cablivy is probably about $8,000 a shot. Look at the amount of time spent in terms of days in the ICU and days in hospitals, and this was all statistically significant, and also the percentage of patients that had a relapse or recurrence, markedly depressed if you added caplacizumab to your plasma exchange, your steroids, and your Rituxan. And so all this was put together by the International Society for Thrombosis and Hemostasis. This was first published in 2020 with an update in 2022, and that is how we should treat immune TTP. The idea is first is you should have a high clinical suspicion you're dealing with TTP versus HUS. That is, consider clinical features. Is there lung involvement versus isn't there lung involvement? Did you do the French score? Is that a high score, which would indicate TTP? In other words, you have platelet counts less than 30,000 and you have creatinines less than 2.3, or is a low score indicating HUS? And if you're clinically certain that this is much more likely to be TTP versus HUS, that it is recommended to immediately start draw the ADAMTS13, immediately start plasma exchange steroids and rituximab. And here it says, consider starting caplacizumab. In our hospital now, we basically always start it. I've been wrong once. And you get the ADAMTS13 results. In our hospital, it takes 5 to 7 days. We're still sending it to Mayo's or other places that take us 5 to 7 days. I know some hospitals outside of New York City get them faster or do it in-house. We don't. Once you get the ADAMTS13 results, if it's positive, meaning you've got a true TTP case with ADAMTS13 less than 10%, continue, or if you didn't start it, start then caplacizumab. If the borderline activity is between the 10 to 20%, consider that this still could be TTP. Gail Rock, the original discoverer of standard of care as plasma exchange in TTP, says that she has many cases that are borderline. And if it's negative, stop all those drugs and consider you need other diagnostic aids. And this is from a paper from the ISTH, just saying what we really are talking about here, because up until recently, most people considered measuring complete response in a TTP type of TMA based on, is the platelet count normal? Is the LDH normal? Is the haptoglobin normal? And I don't really care. The most important part is the ADAMTS13 normal? And as you can see here on the top slide, the clinical response based on patients no longer fatigued, having normal platelet counts, normal LDHs, normal haptoglobins, was very fast, happened here within 3 to 4 days. But look at how long it took to get an ADAMTS13 greater than 20%. It took 25 days from presentation. And during that period of time, the patient is still undergoing presumably subclinical microvascular thrombosis in the brain and in the heart, which is presumably accounting for those longer-term sequelae. In fact, the scariest thing here is that complete ADAMTS13 response or remission is still, in many instances, being considered, let's get that ADAMTS13 over 20%. There's a study recently published in Blood from the United Kingdom where they looked at quartiles of ADAMTS13 between less than 20% to greater than 80%. And in their handling, when they did a 10-year follow-up with these patients, unless you got ADAMTS13 over 60 to 80%, you still had long-term sequelae that you really need to make it normal, which is in our lab somewhere between 70 and 120%, not just greater than 20%. And a paper that was published only as an abstract last year at ASH, but is now, I understand, in final revision for a full publication. This is a CAPLA 500 trial where they're looking at enrolling 500 individuals from 10 countries, who half of them receiving at least 500 receiving caplacizumab. They're actually up to 1,000 now, with 500 historical controls, and showing that it was feasible to start this drug within 3 days of making a TMA diagnosis, that it was adding caplacizumab was superior to not adding it wherever you did it in the course of treatment of TTP, although it was most effective when it was given within the first 48 hours. It led to the need for fewer plasma exchangers, fewer exacerbations, and it now for the first time we have survival data. It's small, but it's real. It increased the 3-month post-survival data from 98%, from 93% to 99%. The 1% potential issue you need to realize, of course, about ITDP if you treat it with caplacizumab is you're inducing a von Willebrand's disease. You're blocking platelets from binding to von Willebrand's factor, and so you're going to have a bleeding risk. In fact, I'd say about a third of the patients that I treat develop epistaxis. It's usually self-limiting, although I had one patient that required packing. It's in my hands, it's basically never been more than that, but in the clinical study published in the New England Journal, the 2 studies published in the New England Journal on this drug, they had a couple of instances. All of them were eventually self-resolving, but they required stopping the drug temporarily. And you should stop the drug for elective surgery, in which case you would need to reinstitute plasma exchange. And if you need to treat a patient, when I leave instructions out for our heme fellows on call, you basically would treat them as if the patient had von Willebrand's disease. You give them UMAP. Okay, let's now go to atypical HUS. Before we knew how to treat atypical HUS, before we knew it was a complement-mediated condition, the only thing we had to treat patients with was plasma. This is a very interesting study from Duke, where they did a retrospective study of 44 TMA patients in their registry, half of whom had ADAMTS13 less than 5% with high titer inhibitors. So these are classic TTP patients. And half of them were considered to have atypical HUS with normal ADAMTS13 activity. And they didn't have complicating factors, like these weren't cancer patients or transplant patients or active infection patients or pregnant patients, et cetera. And they gave them all plasma because between 2007 and 2012, the drug wasn't approved until September of 2011. That's all we had was plasma. And look what happened. If you gave a patient with TTP plasma in the teal bars, 95% completely recovered their platelet count, but so did 71% of the HUS patients. If you gave patients with TTP plasma, 95% normalized their LDH, but so did 62% of the HUS patients. And in terms of renal function, if your creatinine was elevated over normal and you had TTP, 70% of them improved their renal function, at least 25% of baseline. But so did a quarter of the HUS patients. But look at death. There were 0 out of 22 deaths in a patient with TTP appropriately treated with plasma. But a quarter of the patients with HUS died, but they died with normal numbers. And that's what's so important to recognize. Clinicians still don't understand this. I've been involved in several tragic lawsuits where a classic HUS patient with normal ADAMTS13 was given plasma, which is appropriate. As soon as you recognize a TMA from that ISTH guidelines, start the patient on plasma, that's fine. But recognize when their ADAMTS13 comes back as normal that you're not dealing with TTP anymore. Unfortunately, the physician in this most recent case said, but the platelet count's normal. It was 60 and now it's 210. The LDH was normal. It was 2,100. It's now 200. The haptoglobin was 0. It's now 120. And the creatinine, which was in the 5s, is now 2.5. So what more do you want from my life? The patient died the next day, but they died with normal numbers. So this is incredibly important to recognize. There's a follow-up study did at Harvard with about double the number of patients that showed the same thing. Okay. HUS is a complement-mediated disease, and I've mentioned this before. There are several things that can activate complement and set off atypical HUS in a susceptible patient. I mentioned that one of the most potent activators of the alternate complement pathway are anti-MHC antibodies, which explains the incidence of recognition of HUS after a bone marrow transplant or a renal transplant. In pregnancy, virtually all the cases of atypical HUS, this is from a French study, occur postpartum, what we used to call postpartum HELP. TTP is almost only prior to delivery. You deliver and almost prior to delivery. And this almost never occurs in the first pregnancy. It almost always occurs in the second or the third pregnancy, because what happens after the first pregnancy? Well, you immunize against your husband's HLA. You then get an anamnestic response, and it's the second pregnancy that activates complement through high titer MHC antibodies. And that's the condition you need to watch out for. And this is where the art of treating atypical HUS comes in. So you have a TMA, you've ruled out TTP, but you've got these inciting conditions in the teal box on the left. Malignant hypertension. Malignant hypertension can itself injure endothelium in the kidney, can activate complement. And how do you know this just isn't a TMA linked to malignant hypertension itself versus malignant hypertension as a feature of atypical HUS or malignant hypertension triggering HUS? Same thing as with pregnancy. Autoimmune conditions. What if you have a patient with classic lupus, known lupus nephritis, responsive to classic therapies for lupus nephritis. And then the patient comes back 5 years later with high creatinines. Of course she does. She's got more lupus nephritis. Low platelets, of course she does. She has ITP. But it's not responding to normal therapies that you're used to giving. You treat everything on the left. If your evidence of a TMA goes away, that's perfect. But if you continue to have a unstable or low platelet count, or a platelet count that's not within the baseline prior to this condition, if you continue to have some sort of ongoing tissue damage that you can't explain, then consider the fact that you may be dealing with those conditions setting off TMA in a susceptible patient. And this is where you may need other diagnostic help. One of those diagnostic aids could be complement mutations. I mentioned that in the vast majority of cases, about 70% of the time, in this particular study from the French, they found recognized mutations 63% of the time. That's great. But about 30% of the time, the patient may be unable to respond or unable to control complement, and you haven't found a genetic marker. Now, it could be that we're not smart enough, and it's not in the literature of all the things that can affect complement regulation. Recent studies presented at ASH, one of them has just been published, looked at so-called VUSs, variants of uncertain significance, where you identify what is considered a polymorphism because it's in the normal population, say 5 or 6% of the time, the particular polymorphism you found in a complement regulatory protein. But if you bother inducing that mutation in the protein itself and measure its activity, about 50% of the time, that so-called variant of uncertain significance is pathogenic. So just because you didn't identify that mutation, that doesn't mean that there wasn't an inability to control complement. Secondary HUS cases are the most complicated because, as it shows here, only about 5% of the time do you identify a mutation. And yet these patients can still respond to anti-complement therapy. One of the most troubling and the problem I have the greatest perhaps among some of our colleagues here is postpartum HELLP syndrome, these terrific TMAs that occur after the delivery of a healthy infant. And in which case the literature says this occurs in about 1 in 25,000 of all pregnancies. It's really much more common than we expect. And yet for that particular condition in the obstetrics literature, you identify a mutation about 25 to 30% of the time, not 70% of the time. And so I've been involved in cases where they insisted on getting genetic mutations. Luckily, several cases that I've treated here at our hospital, the HUS postpartum HELLP patients did have detectable mutations. But you have to be ready to make the argument that if you don't find one, that doesn't mean that it's not involved. And the little diagram on the left seems to point out that that there are differences in the strength or in the importance of certain mutations, with complement factor B and C3 gain of function variants being incredibly potent, whereas other complement regulatory mutations being less potent. So you may need a stronger activator of the complement pathway in the presence of one of those than in the presence of a complement factor B or C3 mutation. And what about diagnostic aid? What about tissue biopsy? Well, this is a schematic. If this were TTP and you biopsied a small vessel, and these are systemic diseases, so you can biopsy anything you want. We tend to biopsy kidney and normal skin, but anything vascular is fine. You're going to find a clot. If this were TTP, you'd find a predominantly white clot with a lot of platelets. If this were HUS, you're going to find a predominantly red microfibrin clot. If this were TTP, there should be no inflammatory component. If this were HUS, there should at least be some monocytes and some polys. And if you're going to stain for something, if this were TTP, you might stain for those von Willebrand spectrum ultimers. If this is HUS, we stain for the membrane attack complex, C5b9. And this is a slide from the Harvard group published in Frontiers in Immunology. On the left is a renal biopsy of a normal kidney, stained for C5b9. Very, very little staining. On the right is a patient with a typical HUS. You can see massive staining for a complement factor for C5b9 deposition. And then we look at the skin. This is one of our own medical students. This is a third-year medical student who is in a coma. for a month until I walked in and said, we have the wrong diagnosis. This patient had 5 grand mal seizures, was intubated with bilateral lung infiltrates, getting everything that was known to be done for TTP. And I came in and I said, I don't care what the ADAMTS13 is or autoantibodies or whatever. This patient clinically, platelet counts are over 30,000. That's not TTP. The creatinine is in the 3s. That's not less than 2.3. Has lung involvement. I've never seen it in TTP. And you're doing twice daily plasma exchanges and steroids and Rituxan and vincristine and everything. We have the wrong diagnosis. I suggested they went to do a kidney biopsy. I said, just biopsy skin. We just biopsied normal deltoid skin. This is what it looked like. We gave him eculizumab. He woke up in 36 hours, had a complete recovery. Took him a long time, had a complete recovery. I've been unable to stop his drug. He has an underlying ill-defined autoantibody. Every time we stop his drug, it comes back. But we published his case in Blood with several others like it. So don't be fooled. You may need other diagnostic aids. And we did complement mutation analysis, but it took us 3 weeks, and he had a classic complement factor H mutation. So this is real atypical HUS that were just not recognized by the physicians working at the time. Okay, I mentioned eculizumab for the treatment of HUS. This is what everyone would use in the hospital. There's a longer acting form called ravulizumab, but you need a loading dose for that, so no one's going to use that in a hospital in the United States. Wait till the patient gets in an outpatient, then you can convert them. The drug responds incredibly rapidly. If you look at changes in CH50 levels, it goes from 90 to 100% to 0 in about 3 hours. So when the nephrologist asked me, they say, I have a kidney, I'd love to transplant in this patient. This patient has either known HUS or at risk for HUS. How quickly do I need to get this drug in before I can transplant the patient? I say 2 or 3 hours, maybe a day, certainly not more than that. This is the response in terms of platelet counts. Typically, you see a response after the first dose. It typically plateaus after about 4 doses. So it doesn't mean you couldn't see a response after giving 4 weekly doses, but the likelihood is much less. Typically, I see a response within 4 weeks of starting eculizumab in terms of platelets. And look at this. People ask, well, how, does helping ever help? How long do you continue drug? Well, this is one of the original studies published in the New England Journal. What it shows is they had a washout period of 400 days where they took patients with classic atypical HUS and just gave them plasma, as much plasma as you wanted to throw at them, and measured eGFR. And as you can note, in every single time point they measured, there was a decline in eGFR. On day 0, they started eculizumab at every single time point. Up to 2 years, there was no plateau. Still continued improvement in GFR at 2 years. The longer acting form, Ultomiris, has 4 mutations introduced to it. What it does is it basically converts this drug. It takes the normal adult FC receptor and mutates it so that it acts like a neonatal FC receptor. And as you all know, antibodies in the blood from the mother persist for 6 to 8 months because of that neonatal FC receptor change. And basically they induce in this drug. So this drug is maintenance you give every 8 weeks. Solaris, without these mutations, you have to give every 2 weeks. Oh, and then just to show you, this is a kind of a typical case that we had in our hospital where there was a disagreement between the hematologist and the nephrologist to show you how we treat this. It's a 47-year-old male, obese, chronic alcohol use, hypertension. He was supposedly taking 5 antihypertensive drugs to control his blood pressure, but he was poorly compliant, decided to stop them for 6 months. He was living in London. He came to New York City to visit, increasing dyspnea for a week. His relatives then noted altered mental status, including auras for 2 days. Hospital day 1, his platelet count was 270,000, but his hemoglobin was low. His LDH was over 1,000. His haptoglobin was low. His serum creatinine was really high. Well, he's got malignant hypertension. Got blood pressure of 220 over 110. And he was intubated. He had bilateral pulmonary infiltrates. Which they said maybe this is related to his creatinine of 28, so he's got some pulmonary edema. They did a CT of the head because of his auras. They were normal. CT of the chest, they said, could this be a pneumonia? Following consultation with nephrology, they started a cardine drip and hydralazine. Hemodialysis was initiated. He got a couple of packed red cell infusions. On the next day, the platelets decreased from 270 to 140. So we have this 25% decrease from baseline. And in fact, on hospital day 5, the platelet count's now 85. But by just giving him some plasma and some red cells, they brought his LDH from 1100 to 750. They brought his haptoglobin up from 40s to 60. Finally, a hematologist was consulted who looked at the blood and found schistocytes and drew an Adams TS13. And the issue here is, despite the fact that his blood pressure was now controlled on 2 IV medications, his thrombocytopenia had worsened. On hospital day 13, his Adams TS13 comes back within normal limits. Again, it takes us about 5 to 7 days to get it back. They decided to do a renal biopsy. And the nephrologist and the hematologist both look at the biopsy. The nephrologist said, this is HUS unmasked by malignant hypertension, start eculizumab. But the hematologist disagreed. He said, this is malignant hypertension, but that can cause renal damage. The biopsy showed both acute and chronic changes. He thought the relative low number of schistocytes, 1+, was incompatible with a creatinine of 28. But he agreed to give 1 dose of eculizumab if I sent off complement genetics. They asked me to come in to adjudicate this as a consultant. And they agreed to say I could send off complement genetics. If it came back positive, they'd agree to continue eculizumab. If it was negative, they were going to stop and just attribute this all to malignant hypertension. The reason I present this is not the way to make a diagnosis. A typical HUS, TTP, you have a gold standard, an Adams TS13. In HUS, you do not have a gold standard. It's a clinical diagnosis. You rule out everything else. And what you're left with, if it's compatible with HUS, that's what you're treating. Because if you try to rely on complement genetics, then you're going to be wrong at least 30% of the time. But, I like to go to Vegas, you gamble. We send off the genetics, and luckily, he had a classic pathogenic complement factor I mutation. Got a 2nd dose of eculizumab, is now doing very well. They administered his 3rd dose. He went home, and he actually sent me a video off dialysis, doing very well. It was really atypical HUS. Okay. People often ask me, these are really expensive drugs. That yearly treatment, either with ravulizumab or eculizumab, is in the $500,000 range. If you start this drug, can you stop it? And there are multiple papers on this. I published basically my ideas as a review in 2020 in Clinical Advances in Hematology and Oncology, where, how long do I treat? The typical patient in the United States treated with eculizumab is treated for 5.7 months, and then they stop. The important point here is it should be individualized therapy. So you've treated a patient for 3 months, and you reevaluate. The patient is in a complete remission. They're still in a complete remission. You treat for 3 months more. You then have a decision point. Should I continue treatment, or can I stop at 6 months and just closely monitor the patient? Well, first of all, is the patient adherent? There are multiple studies, one from Johns Hopkins, one from France, showing that if you have a patient who's non-compliant, because we're going to send these people home with urine dipsticks to monitor their urine a couple of times a week and then less frequently for protein and hemoglobin. If they can't do it, and you can't start the drug within 48 hours, then you don't want to stop. And so if you're in the blue box and you're relatively good, you don't have a renal allograft. In the United States and most of Western Europe, if you had a prior kidney transplant with HUS, we never stop drug. You're on it for lifelong. If you haven't had a prior TMA, in the United States, usually we let you have 1 prior TMA. No extrarenal manifestations, which are harder to treat. No anti-complement factor H autoantibodies that haven't resolved. No pathogenic complement gene mutations. Then we withdraw therapy after 6 months with close monitoring. If you're in the red box, you've had a prior renal allograft, you've had multiple prior TMAs, you have CNS disease, you have pathogenic mutations, we tend to treat for another 6 months, and then in consultation with the patient, consider withdrawing. But again, personally, we do not do that in the presence of a prior renal allograft. This is from a paper published in Blood from a French study showing that if you're one of the 25 to 30% of patients that had no identifiable mutations, that's in that top line, then your survival with no evidence of relapse was at least 24 months. That's when they stopped the study. So we feel very good if there's no mutations to stopping drug with close follow-up. As I mentioned before, there's that little bit of a caveat that if you have these variants of uncertain significance, we very closely follow you. And then finally, so where are we going to go from here? We've got two expensive drugs that are life-saving. One of the reasons why I love to do these grand rounds, I love to do talks about HUS and TTP, is I tell people that particularly in terms of HUS, where we don't have a gold standard, that something I said today, you're going to remember a patient you saw a year ago, or you're going to see a patient tomorrow whose diagnosis you would have missed because you didn't consider the fact that it could be a typical HUS. But the therapies are very expensive. You don't want to be wrong for a long period of time. This just points out that there are multiple drugs now, multiple pharmaceutical companies that realize there's money to be made on inhibiting complement. So apart from blocking C5 with eculizumab and ravulizumab, there are also drugs to inhibit the lectin pathway of complement, narsoplimab, which is in phase 2 studies now in PNH, going into studies in HUS, already in studies in TMAs associated with transplantation. There are other drugs, some of them are oral, some of them are subcutaneous, that are either approved or in trials for PNH, where the drug companies are looking at a much bigger market, and that is complement factor H. So over the next year or two, you're going to hear about other drugs that are possibly useful. And in fact, two things are happening. In March of 2025, eculizumab goes off patent. So you're going to have biosimilars that are presumably going to be significantly less expensive. And you're going to be used to those. And there'll be presentations at ASH about that. And then two, we have drugs like crovalimab, which are easier to take and less expensive, that people are contemplating, and drug companies and insurance companies are contemplating to suggest should be used for the treatment of some of the diseases as well. Okay, so in summary, TTP is typically an acquired, or 5% of the time, congenital deficiency of ADAMTS13. Atypical HUS is diagnosed clinically. We don't have a gold standard, depending on recognizing the signs and symptoms of a TMA while excluding other causes of a TMA, and also paying attention to things like the plasmic and French scores. Plasma exchange is only a temporizing treatment in TTP. We used to consider it the treatment. It's not. The pathophysiology, anti-ADAMTS13 autoantibodies, must be addressed with effective immune suppressive regimens. Mounting evidence suggests immediate intervention to block platelet von Willebrand's factor multimer formation with caplacizumab should also be utilized. That's a misprint. It should be platelets von Willebrand's factor. Plasma exchange does not address the underlying complement dysregulation that causes HUS. As I showed you in slides from Duke and Harvard, it can normalize the platelet count, the LDH, the haptoglobin, and the hemoglobin, and may also decrease the creatinine, but it does nothing to mitigate development of end-stage renal disease and does nothing to impact survival. Complement activating conditions can trigger HUS. We can identify what those conditions are about 2/3 of the time. You should manage those conditions for your standard protocols. A lack of response to treatment should raise suspicion for HUS and the fact that you need treatment directly in terms of anti-complement therapy. And then finally, certain techniques may provide additional diagnostic information in a complex case, presumably those involving allotransplants or malignancy. These include kidney and skin biopsy and complement mutation analysis. And I will stop there. Thank you.
Dr. Laurence, thank you for a really enlightening talk here that's extremely informative. As a cardiologist, I'll just say that I need to make sure that I call my oncology colleague, my hematology colleagues, certainly for any suspicion as the complexity of this continues to evolve and treatment modalities continue to improve, which is really impressive. I just want to encourage anybody to either please raise your hand, put it in the chat box for any questions, or just speak up directly. We have some good time for some questions and discussion. And while waiting for that, just to ask, going back to TTP and bringing together the treatments with rituximab, steroids, and Caplyta, can you comment on the durations of those therapies? How do you manage them over time, and what do you look for?
So that the nifty thing about the use of Caplyta is that once you've started Caplyta and the Adams-13 is over 20%, you can stop plasma exchange. In fact, there's an ongoing phase 3 trial now of omitting plasma totally from the treatment of TTP. Just treat the patient with Caplyta, steroids, and rituximab, because basically you don't need to replace Adams-13 if you're giving Caplyta and blocking the interaction between platelets and von Willebrand's factor. And so you can use plasma-free therapy. And Jim George, who's the doyen of this, who has the largest TTP registry in the United States in Oklahoma, has written an editorial in Blood saying that, you know, we look forward to the day where we no longer have to put central caths in, no longer have to use plasma with all its risks. In terms of duration, the package insert for Caplyta says you give it for the first 30 days, but you can stop it. You can stop it before the 30 days if you've gotten the Adams-13 over 20%. If you haven't, and we've had, I personally have not seen any of these patients, but I got a consult from Israel last night. I just read it this morning, but I knew it was coming, of an individual that they've been unable to treat despite Rituxan, steroids, cyclosporin, the replacement for Rituxan. They've been unable to get the Adams-13 titer to decrease. And you know, I informed them about Caplyta. You can give Caplyta for another 28 days, as long as you need it, as long as the Adams-13 is no longer over 20%. So I guess a long answer to your question is, vast majority of cases, package insert says first 30 days. We have found that you don't have to give it for the whole 30 days if the patient is rapidly responding, but you may need it for an additional 28 days afterwards.
Thanks. And what about the rituximab and the steroids? Where does that fit in?
Right. So
basically,
you need to use immune suppression until you get the Adams-13 over 20%. Okay. And I would say that's inadequate. In our own physicians here look at it to get it over 50%. And if you believe the British study in Blood, you want to get it to that normal range that is over 70 to 80%. And so as long as it takes, typically we give 4 weekly doses of Rituxan. And in the vast majority of cases, we get a response. If there's a relapse, you just restart the Rituxan. There's no, the patient, if it responded the first time, will respond the second time. If they don't respond to Rituxan, as in this case from Israel, our particular algorithm is we tend to go to Velcade. We tend to go to the proteasome inhibitors to block those, to block the plasma cells, just as we would for recalcitrant trace of immune thrombocytopenic purpura. And if that doesn't work, there are multiple other things you can do. There's an article in the New England Journal about 8 weeks ago that I wrote a letter in about, that was published about 3 weeks ago, where they took a patient with what they thought was recalcitrant TTP that was on Rituxan and not responding. They couldn't reduce the titer levels. Adams-13 still in the 0% range, that they gave recombinant Adams-13 to. And they had a complete response. That is not the way you treat this. They used a short dose of Caplyta. They should have used a longer dose. There was a lot of criticism of that. So we have multiple modalities, but sometimes it's really tough. We've even gone, when Velcade hasn't worked, to R-CHOP, to Rituxan and Cytoxan and Oncomin and prednisone.
Wow, thank you so much. Appreciate that and the real insights on that. Other comments or questions?
And also in terms of cardiology, since you mentioned that,
yeah.
So the cause of death, we focus on the kidney with the creatinine of 28 and so forth. If you die from this disease, as I mentioned, some lawsuits I've been involved in, and when patients relapse, you die a cardiac death. It's typically either a myocardial infarction related to multiple microvascular thrombi, not large vessel thrombi,
Right.
or EM dissociation. And people don't recognize that enough. And now that people are doing cardiac MRIs, realizing that unless you get that Adams-13, probably over 68%, not even 20%, you're going to be at risk for that.
Yeah, no, thank you on that. And I don't know that we have directly documented those kinds of things, but we're certainly aware that on the cardiology literature that that's a presentation for these heart failure patients, myopathic patients. So thank you on that as well. Other comments or questions for Dr. Laurence? You've given us a lot to think about, certainly. Maybe while we're waiting, I'll just add one more question to ask you. Just in this, in the development of TTP, and maybe you comment on this, I might have missed it. What are the precipitators of developing these antibodies in all of these acquired TTP cases? Are there specific premonitory events that are really inducing this?
Right. In HUS, they're clear cut, and there are multiple of them. In TTP, it's less than clear cut. The classic ones are HIV can certainly do this. Influenza can certainly do this. H1N1 vaccination has been associated with starting it off. And in that medical student that I mentioned, who will be on drug presumably lifelong, he started out with an Adams-13 less than 5% and a high titer inhibitor. And his trigger seemed to be, he had some ill-defined mixed connective tissue disease when he was young. I guess it returned. We easily got rid of his inhibitor, but he because he had also a common factor H mutation, really had HUS, and that's why we had to treat him for HUS. But his trigger presumably was this autoantibody related to his autoimmune disease. But a lot of times it's really unknown. The population that's most at risk and that we're most concerned about in terms of close follow-up are African-American women, particularly Afro-Caribbean women. Afro-Caribbean women in general have a higher incidence of autoimmune diseases, and basically acquired TTP is an autoimmune disease, so that's not surprising. But about 6% of the cases of HUS that are unresponsive are Black, typically Afro-Caribbean women, and we have a cohort of those patients that we're following here.
Thank you. I see that we have Dr. Kra. Dr. Kra is one of our hematologists, oncologists. Dr. Kra.
Yes, hi. Thank you so much for this wonderful talk. When I was on service just last month, we had a complex case of a woman who had been at multiple hospitals. Diagnosis of atypical HUS was made somewhere along the way. We were trying to figure it all out. And so, your talk it's a lot of consternation we get as hematologists, these atypical HUS cases, because as you mentioned, there's no gold standard test. And so it's really using a lot of clinical kind of acumen and understanding. My question for you is more just, for the medicine audience, these TTP patients, we've done a really great job, I think, at getting them, under control, whether it's rituximab, steroids, Plex, and then obviously now Caplevi. The patients who go into remission, maybe you could just kind of comment on how we monitor them. Are you a big proponent of checking Adams TS13 levels in the clinic, every couple months when the patients are in remission, giving preemptive rituximab? What's been your kind of philosophy on that?
Right. So I do both. We tend to follow these patients closely. Certainly within the first couple of years, we're doing Adams TS13 testing 3 to 4 times a year. We have used preemptive Rituxan if they responded to the Rituxan before, when their Adams TS13 goes below 20%. And I think that's vital. And I think that many people in our unit are also calling me, considering it when it falls below 60%. Because of the new data that we're seeing related to this subclinical cardiac and cerebral events. And that should be lifelong. This is something that you need to do lifelong. Typically after 3 or 4 years with no relapse, we see the patient twice a year. But we see them, basically, we recommend seeing them twice a year forever.
Thanks so much. Maybe we have time for one more quick question. I see Dr. Schutzer has his hand up.
Thanks. No, that was a great talk, Jeff. are you aware of these absorption experiments to pull out the autoantibodies, like going after the constant region? And because I know there's a group in Germany, they're trying to get FDA approval here, and they presented this at the NIH. And so, and they did use a chemical, I think they just called it CHUS, which they had some effect on. They're mainly going to look at long COVID and ME CFS, but
Yeah, so the answer is yes. I'd say about 20 years ago, Dr. Nachman, or 25 years ago, Dr. Nachman, who was then chief of hematology and then became chairman of medicine, treated one patient with one of these immune absorption columns that was totally unresponsive to everything that we knew back then how to do for TTP. It didn't work, and the literature basically, I stopped looking at it. I haven't seen anything. We have so much more direct ways of treating this condition, and now with Cablevy, where you can interact literally within hours, I don't think just temporarily pulling out and the autoantibodies with a column is kind of the way to go anymore.
On that note, unfortunately, our time is up for this morning. I want to thank you, Dr. Laurence. Really a wonderful, wonderful talk, extremely enlightening and informative, and I think a great learning for everybody. I want to thank everybody for joining this morning, and wish you, Dr. Laurence, and everybody else a great rest of the day. Thanks again very much.